I've got a talk which is about 15 slides, and there's a natural break in the middle, so we can sort of try and play this a little bit by ear, and if you want to kind of pitch in or criticise me, whatever, as we go along, that's fine. I'm going to pick up the theme that I was emphasising earlier on, which is there's these two sides of the story. There's data and there's knowledge, and I'm going to try to, in this short time, to be clear about what the distinction is. I should also pick up, I think it was Tony made the point, that this is, it's not clear what's upstream and what's downstream. There's data that comes out of clinical practice, but you obviously start with a body of knowledge, mostly in human heads and books and clinical guidelines and so on at the moment. But now what we're trying to do is, and other people are trying to do, is to take the current knowledge and translate it into useful point of care services, which will lead to new data, which will lead to improvements. And there'll be a number of cycles in this talk, I'm afraid. So just to remind you, for those of you who this is new, this articulation of how we try to improve quality, safety of patient care, and, by the way, translate new research into practice, is attributed to this workshop organised by the Institute of Medicine, which reported that as we try to move towards personalised healthcare, and medicine becomes increasingly impossible for human beings to do unaided, we're trying to develop organisations, institutions, technologies that will support in a sustainable way progressive and rational improvements in practice. And a couple of things more have also kind of chimed with that. One, we were expecting John Loader to be here, I think, from Nesta, but couldn't come. And he was with Jeremy Wyatt and I can't remember who the other author was, but they wrote a report you can find on the Nesta website called Dr. No, which is towards a knowledge commons for healthcare, and the vision that they paint there is that we are now in a position, technically, to create resources, national resources, for the NHS or international resources, which will capture knowledge in a way that people can use in research, in clinical practice, in patients looking after themselves, and they're calling for ways of doing that. That's actually an older idea, and particularly associated with somebody called Bob Greens in the States, who observes the notion that wouldn't it be wonderful if we had not only repositories of clinical guidelines like those created by NICE and many other organisations around the world, but also bodies of knowledge that could be used explicitly by computers to help support clinical decision-making, evidence-based practice, and so on. So there are two things coming together here. There's data about every aspect of patient care, and particularly the patients themselves, and there's knowledge that we can use to improve the quality of decision-making and learn from the outcomes of that to progressively improve things. And OpenClinical its origin is actually quite a long way back, because I attended a meeting in Boston of a small community of researchers who were interested in I think we used the phrase knowledge sharing or sharing clinical guidelines, but in this computerized sense, in which there were a number of groups already developing techniques to make this possible. But it seemed to become clear to me, slightly alarmed, that there was also a considerable commercial interest in the content that would be created and the value created by being able to computerize the kind of material that NICE produces. And that a large number of products and services and ways of turning a profit would be made possible by making large collections of that kind of information available. So I sort of felt that what we needed was a kind of open access, open source, publicly usable repository of the same sort of content that would add value to traditional knowledge sources. And here we go. We ended up with another one of these cycles where we would start with different kinds of content, results of clinical trials, systematic reviews, guidelines, evidence, all that stuff we're all familiar with. But what the community, the medical informatics community that discussed this in Boston realized was that we can take the content, capture the medical logic, the evidence, and turn it into, formalize it in various ways that a machine interpretable can then create repositories of that content for people to make use of, to create their own resources. So if you have a diabetes pathway or a hypertension decision support system or a GP cancer referral application, the content could be accessible. Lots of people could create applications using that content. Everybody isn't constantly recreating the wheel. You can create national and international consensus as embodied in this knowledge, and then people can compete around adding value with particular products in the standard sort of open source software model. And then to deliver the services based on that content at the point of care, support clinical research, patient empowerment, and of course closing the loop, as we've talked about more than once. Recording outcomes, recording adverse events, and learning from that process that this is now additional source and additional material that leads to the next generation of guidance, pathways, quality standards, and so on. And rather more years later than I thought it was going to take, we have on OpenClinical our version of that kind of vision, which has about 50 or so applications on the repository. And you can go to the website, www.openclinical.net, and have a rummage around. There are a small number of applications that you don't need an account for. We haven't really gone truly open yet, unfortunately. We're behind our schedules. Still quite an early stage project, but I think what we have shown is that we have all the technology in the jargon and end-to-end technology to allow people to create and share their own expertise. And here's just some screenshots of 2 or 3 examples. The first one, this was developed by an A&E doctor called Mark Gutenstein, who's in New Zealand, who took a nice pathway and plus his own expertise and converted that into a form that you can see. Well, I don't know whether you can see it, but that little diagram. By the way, later I'm very happy to show all this live and give you demonstrations. Obviously, there's too little time now. But created a workflow, a pathway that was machine executable, so that could support, the initial triage, the workup, the decisions about imaging and the final disposition, whether the patient's sent home or admitted, and so on and so forth. That was as one example of a doctor himself creating an application which could then share that potentially he himself or his peers could use that content to run clinical trials, to test it, validate it, by putting their own patients through it and so on. Another example, which is I've only picked just because it highlights a different point, because we were talking about distributed ways of doing this. That's very much that acute head injury application is very much a centralized sort of model that you would manage the clinical process from a single server. In this model, this was developed by a group of my students in Oxford last year. The model is one that everybody is trying to do with apps. Part of the application is used by a patient perhaps with hypertension, running on a smartphone, and they're recording information on a daily basis, maybe getting a little bit of support about decision making, whether to make an appointment with the GP. But the other half of it is actually running on the GP's own machine, with a lot of additional things like doing trend analysis, doing risk assessment, popping up alerts when perhaps the GP should be contacting the patient. And saying maybe you'd like to pop in and we'll just have a chat about whether we've really got your hypertension under control and making some recommendations for changing the medication or some other action. And of course all of that data being captured and consumed by analytics software and machine learning and the kinds of things which are so fashionable at the moment. A third example, being a kind of an engineer, I called myself a scientist earlier, but I've been contaminated by engineering. So I like to be able to kind of take all this stuff and reuse as much as possible, and having standard components that we so people don't have to constantly reinvent the wheel, even within the OpenClinical project. And couple of examples I would pick out are a pathway that was many years ago designed by a gastroenterologist I knew at the Whittington Hospital, and he designed these pathways or on paper, but we turned into an electronic version. These are templates that anybody wanted to create an outpatient pathway could take that and then populate it for different conditions that they were concerned with. More recently, we discovered the project at the Royal College of Physicians on clinical headings, which was then published by the AMRC as a standard for things like admission, discharge, referral, handover, and so on, a standardized structure that could be used for lots of different applications. And we turn that into a component that you could kind of plug in. You don't have to reinvent this every time, but when you build a pathway, you say, we'll just take the AMRC standard and plug it in, and it will automatically capture the data according to the standard. I gloss over some significant technical details, but that's basically the concept. So the way, the dream for the future is that repertoire will become a publicly owned content repository covering a wide range of pretty much anything in medicine as far as we can see, that will add value and reuse all the content provided by NICE and other specialist guideline organisations. As I said, we have about 50 demonstrations. They're not kind of, many of them, clinical strength yet. The main point, what we've got to, is the point where we know we can do this. Now what we need to do now is to scale this up. We have had some discussions with, for example, NHS England's care for coding. What's code for health? What's it called? Code for health. Thank you. Where the concept is, how do we empower doctors? Get the power out of the hands of technical people like me who don't understand medicine, and then give these tools to healthcare professionals who create what they need, and share it among themselves, adapt it, improve it, and so on. And my second set of cycles, there's actually 3 cycles here, just emphasizing that once you can deliver these kinds of services, you can provide assistance to the individual clinician or the patient, so the point of care, to the provider organization, feeding back what happened, what were the outcomes, if the clinicians decided not to follow the guidance, why, what were the reasons, what were the context, and then feeding back to the originators of the core content to inform the next revisions of their published guidelines. And we did a couple of papers about that. So I'm sorry, that probably took far longer than I intended it to take, but that's sort of where we kind of stop. The second half is to kind of go and talk specifically about the learning side of things. Is there any kind of quick questions, issues? Yeah, please.
So with my very nice glasses on, I'm looking at this with kind of envious eyes and thinking, God, why didn't we do this at NICE? Or, a lot of our information, why aren't we presenting it in this way? And do you think you probably will say yes, but what's the value in another function doing that instead of NICE as the source?
So why did we do it?
I suppose what I'm saying is...
So we were researchers. We were saying, there's a huge amount of effort. I mean, if you go to something like the National Guideline Clearinghouse in the USA, which publishes the clinical guidelines from 300 or thereabouts organisations around the world, just the English language ones, of which NICE is the biggest contributor. But everybody was publishing in non-standard form all these guidelines. And there were all sorts of issues, as many people are aware of, surrounding their actual impact in practice. So what we and our colleagues in the medical informatics research community were asking ourselves is, how can we use advanced IT and artificial intelligence to kind of add value to all of that enormous amount of effort? So we did it, and we kept on going, and eventually ended up with something which is, to a first approximation, seems to be a sort of fairly complete. Now, there's no reason to believe that we've actually done it the best way possible. It couldn't be improved, but it does exist, and it does have a set of standards that can be exploited. So I know that NICE has been increasingly thinking about this whole area for 2 or 3 years as part of your digital strategy. And hence the question I asked you in the session, I'm puzzled that they haven't actually really kind of grabbed it and said, let's run with this. It's still, I think, very oriented towards, as far as I can see, very oriented towards conventional electronic content, electronic publishing. You can do a lot of things with fairly conventional electronic means. but it's still, there's a big move forward to actually start giving advice, particularly to doctors and other professionals.
Because I just wonder, as a user out there, with your offering and then all the different agencies or groups that have their own, does this just add to the confusion? Because how do we make this the one-stop shop?
How we actually deliver it at scale is nobody knows. Nobody's done anything like this before. Haven't got a confident answer. I have lots of opinions, and I'll share them with you, at a moment's notice. But we don't really know. I mean, but there's certainly lots of different paths you could follow. One of which might be that NICE would say, well, why don't we, in a moment, if we go to one of a topic like COPD or low back pain or whatever it is on the NICE website, you'll find the guidance, that big 40-page or 60-page document. You'll find the pathways. You'll find the quality standards. You'll find a bunch of other things, all to do with that subject. Why shouldn't there be another button where somebody says, actually, I'd like to go run my patient through this and just see what the NICE guideline would actually recommend? Now, that would be an incremental step just to see if it worked. Maybe we could do the same thing for depression. Acute depression, GP says, I just don't know whether to refer this chap or not. There's lots of ways you could just begin to start doing small-scale trials and experiments, and I think we've got technically to the point where that we can deliver that.
And I know I'm dominating, but I'm just thinking whether the way forward is about collaboration with the functionality you're producing here and us getting into bed with you,
right?
Rather than where I think NICE can get focused on trying to be all things to all people. And
well, I don't think, what I was trying to say in my previous point is I don't think it's yet another, I don't think it's an addition to the chaos, to the Tower of Babel. I think it's an incremental step which potentially would deliver a big step in terms of improving consistency of delivery.
But to get the collaboration could make that incremental step a bigger step.
Yes, please. Yes, please. Happy to have a discussion. Very happy. Thank you. Thank you for your support. Okay. Yeah. Tony.
Apropos of that conversation, were we to want to go to Zurich tonight, would you go to BA, Swissair, Expedia, Travelocity?
Right.
That's the digital world. The digital world, you have a choice. You can book the same ticket on the same airline through lots of different portals and places, and it's the nature of a digital world. It's not, we do that, why are you doing it? Sorry, I'm caricaturing.
No, that's fine, that's fine.
Or we should do it together, because I think it's just the world is multiple.
But as a clinician, you can sort of be damned if you do and damned if you don't. You can be damned if you do follow guidance, and you can be damned if you don't. But you've got to have that standard there underpinning that. And all of those websites will use certain standards, won't they? They'll use certain technical and information standards.
I was more thinking you could take do exactly what John said. Take a nice guideline and propose it to people as a static thing, as a very dynamic thing, as something you should hook to your patient record if you want to do the thing, or somebody else may do it as a way which would process research data through it, or there are lots of ways of serving that content to people, and one person can't serve it all those ways, so we're going to get multiplicity.
No, yes, there's lots of things I could say. I think I would actually, though, emphasise one. There's lots of obstacles to success, and now the focus group we've just had, was trying to explore obstacles to the adoption of these kind of new technologies, and one of them that I felt was around the table, and I think David Ingram, would be the first to kind of lead the charge on this, is actually what you're saying about integrating with the patient record and the issues of interoperability that are created by lots and lots of different providers and different technical services which don't necessarily follow consistent standards. That is a real issue for us. I think Open EHR, which David's very much involved with, is an attempt to mirror the OpenClinical knowledge effort based but around data and consistent use of that. Sorry.
I was going to say, my point is they're all hitting the same airline database. That data is very standardized and swapped around. It's simply I prefer Expedia, you prefer the channel, and in a sense, this kind of knowledge is better served by multiple channels than it is, for the word channels, than it is to imagine there's one channel that will serve it to all people in all flavours.
Yeah, and OpenClinical is absolutely, that's the spirit of it. It's trying to say we don't want to own the platform or the channel. What we want to do is to create the raw material that allows that kind of diversity and also empowers clinicians to kind of determine what they get and what they provide for each other.